there's also medical, they're medical staff, right? They're part of the medical staff, but they're also employees. So it's a different dynamic, and it is even at other. And I know you said there's shades of gray, and I think we're kind of maybe one end of the spectrum, and that is employed physicians.
Yep, that's quite true. And in a lot of hospitals, there will be employed hospitalists, for example, sometimes anesthesiologists. Then it gets even more complicated because hospitals can contract with hospitals can contract with hospitalist groups, or especially emergency department groups or anesthesia groups. And then you have people who are members of the professional staff who are in the OAG or something like that, which is a different thing. And then in my institution, Kaiser, the insurance company, wherever it sells insurance, it contracts with a group of physicians to provide exclusive care to Kaiser members, and those are called the permanent medical group. So I'm a member of a 900 physician group practice, which is so it has its own internal dynamics. It's a corporation, and it's its own leadership structure that's different from the hospital leadership structure. So that's a little complicated too. But ideally, the bylaws are supposed to recognize really none of those things. The bylaws, the independent professional staff structure is a thing unto itself, and it has no formal relationship with Northwest Permanente or OAG or a group of ED docs or contracted or anything like that. It is a thing unto itself for that institution. Privileges and medical staff structures are for specific hospitals, and so every hospital has to have its own. So anyway.
So in Oregon, nurse practitioners or LIPs, does Kaiser not use NPs or not see them in that capacity?
Yeah, I think largely because the Kaiser practice Kaiser has 35 hospitals. So it's, and most of them are in California. There's one here, so to be another, and then one in Hawaii. And so the practice in Kaiser hospitals is for licensed independent practitioners to be allied health clinicians, and allied health clinicians apply for privileges, and in the same way that members of the professional staff apply for privileges, they have some rights that are not the extensive HICWIA rights, but fair hearing rights that are defined in the bylaws. But they're not members of the professional staff, and so their care is overseen by members of the professional staff, and all patients admitted to the hospital have to be admitted by members of the professional staff. So they can't practice independently. So the nurse midwives and other nurse practitioners can't practice independently in the hospital, even though state law allows them to. But I think state law in California is more restrictive about that, and I think it's because of that model that's the practice in my hospital. I think in other hospitals they are able to have a more independent practice. Yep.
They do federally. Mm-hmm. They do federally. Federally, at least in the mental health, they independent.
Very independent practice, yeah.
Right. They can't admit better than that.
They can't admit,
and they can't do clause B. Other than that, they can prescribe.
Can't do what?
Clause B prescriptions.
Oh, yeah, right, sure.
So, in your opinion, the whole system of the hearings and the appeals process for disciplining, does it work well? Do you feel like you're able to, when there's people there that you don't think should be there, you feel them efficiently, or do you feel like your hands get tied sometimes?
The overriding principle is that you have to do what's right for the patient. And so in spite of the clunkiness of the fair hearing process, you still have to do what's right for the patient.
Sure.
Yeah, so, but the process itself necessitates the hiring of an attorney. to go through it with you.
Okay.
And a colleague of Barbara Nay's, Chris Kitchell, is an attorney that I'm really glad is on my side. Because when she starts sort of vamping on different approaches she could take to screw the other guy, I'm really glad she's mine. Which is really a good thing to have someone really skilled. She's a litigator at litigation on your side. So we've always been successful, but it does necessitate, you can't be cavalier about it.
Right.
Right, and you can't do it for, without a solid case. Proceed down this path without a solid case. And usually, I mean, it's like anything with, so there's another topic I'd like to bring up, which is, you know, our forum discussions have really been focused on punitive actions that can be taken. And how many people here are familiar with just culture or quality improvement, just culture sort of things? So we had an interesting discussion before we collectively about communication and the importance of physicians communicating well with one another. Indeed, in hospitals and in hospitals and outpatient care, the times of major risk for the patient is the time of transition from inpatient to outpatient, where medications get screwed up and they're taking both the Lanoxin and the Digoxin, and transitions from the intensive care unit to the floor, where there might not be a proper sign out. So those are areas where the communication needs to be really good. And then, of course, we were talking about it in the context of physicians communicating with one another about errors. What we haven't explored sufficiently is the just culture concept, which is that if you have a punitive culture in your institution, nobody's going to say nothing to nobody. Okay? So you're not going to, if Dr. Smith is afraid that you're going to ruin his career anytime you bring something up to him, Dr. Smith is never going to hear anything you say. He's going to be reacting against everything you say. And as a matter of fact, nobody will talk about anything with Dr. Smith because of fear of retribution. So there's a culture of fear that operates, this is probably most, the area where this is most apparent is the operating room. So it's kind of a microcosm of the culture of the hospital. So I mean, some of the people who do this work in the audience here some of you will appreciate this. So Dr. Jones walks in and he's going to amputate a foot. And the foot's all gangrenous and looks terrible and it's dead and it's black, but the other foot doesn't look a hell of a lot better. And the foot is prepped and draped and everything like this. And the nurse says, "Damn, I think it was the left foot that was going to be amputated, not the right foot." But the nurse doesn't say anything, and the wrong foot is amputated. So why did the nurse not say anything?
Usually fear.
They're trained to not to.
Fear, retribution.
Maybe they're trained not to, fear of retribution,
They've been
absolutely.
yelled at before to that position.
Exactly.
But don't they still have an overreaching responsibility, regardless of all of that, for what's right for the patient? I
No,
mean, if you know that, I mean, that's obviously bad for the
And that's
patient.
exactly the point, that in spite of what's written on paper, that they should have an overriding obligation for the patient care. it's not uncommon, at least historically it's not been uncommon, and there are really vigorous efforts to prevent this from happening, but historically, the fear that the individual in the operating room, be it a nurse or a tech or whatever, can feel from a toxic work environment, especially, a toxic environment with the person in charge, the surgeon, will override that person's willingness to consider, to think down the road of what the consequences would be for the patient. And that's not uncommon. And that's a little frightening to think of, but that's not uncommon. Now, it's become much less uncommon because assholes in the operating room are getting disciplined. And there are very formal programs in place to try to break down the barriers to communication in the operating room. And those have borne a lot of fruit in the last decade, and we can talk about this a little bit. Elena had a question behind you.
Well, it's not a question, but like a comment to add to that whole mix.
Yeah.
Because I work with surgeons regularly and deal with quality assessment. The things that they're required to do now to prevent those types of situations, and the hospital created a different culture based on the research that was done, is the pause or the checklist. And it's required. I mean, part of the documentation for surgeries or any sort of invasive procedure is that it's check marked off by the surgeon in their notes that a check was done and who the nursing staff was that started the checklist. So it's a bit more inclusive now. Everybody's responsible for. I mean, it's required to do a pause. There's always a checklist, and when it's not, that's when disciplinary actions come into hand, because there are some charting requirements that quality checks every 30 days, that they review all of the surgeries that were done, and there are specific things that NISQIP requires and that they have to allot for. And when something isn't done, it immediately gets sent to the department head. Mm-hmm. It's not something that comes 6 months later or 3 months later. It comes that month, like within 3 weeks of when that procedure was done.
Sure, we'll talk more about that. Mary,
Yeah, I was just going to say, in a toxic work environment, the other thing that can happen is that the tech or whatever's self-confidence gets beat down so much over time that part of their mindset is, I must be wrong.
Right.
And so it's not that they intentionally didn't do what was right for the patient, but that their self-confidence has been beat down so bad
they're not part of the process.
They just assume that they're wrong when they think
that's really kind of what I meant when I said that they've been trained that way. I mean, that's not a structured training so much as the culture.
So is the surgeon the captain of the ship?
The newer patient-centered model, no, not so much.
So is the surgeon ultimately responsible for always the surgeon the captain of the ship?
Yeah.
So you used to hear that. I'm the captain of the ship. And so the culture then was the surgeon was the person making all of the decisions and was the captain of the ship and was directing all activity in the operating room and was ultimately responsible, and you better do what I say or get out of my way. So that's pretty common perception of the surgeon in the operating room. And now what we've learned in the last, a lot of stuff borrowed from the airline industry, actually. Another Oregon connection. When the airliner went down in Northeast Portland, I don't know if many of you were here to remember that, but I was actually answering telephones at the Portland Clinic as a night job in medical school when that happened. But the captain of the ship there was the captain of the airship. And the captain was so involved with being the captain that although people were telling him that your airplane was running out of gas, he didn't hear it. And there wasn't a culture of communication sufficient that he could land the plane before it ran out of gas and fell out of the sky and landed in the neighborhood in Northeast Portland. So that's what's seen in patient safety, for the history of patient safety, as being one of the watershed events that led to a lot of work crews of airlines to ensure adequate communication. And that information, and so American Airlines are unbelievably safe these days, largely, especially compared with then, because of a lot of work that's been done on crew resource management for airlines. So the ability of everybody in the cockpit to communicate. So this is what I hear, and I don't know if it's true, but it's sort of apocryphal, that the number one determinant of whether your airline or the airplane that you get in is going to make it to its destination safely is whether the pilot and co-pilot or the crew have worked together before. Now, I don't know if that's true or not, but that's what patient safety people like to say. So what does that mean? Well, it means that if you have a very vigorous program to teach everybody to flatten the hierarchy, make sure so you don't have a captain of the ship here and everybody else down here. Flatten the hierarchy, make sure there's good lines of communication between everybody, among everybody working in the cockpit of the airplane or in the operating room. Suddenly the communication is enhanced and bad things don't happen because you find out about them before they happen. So that sort of approach over the last decade has been taken in operating rooms, and they have things like the pause, and you're supposed to check off whether the pause has occurred or not. And the purpose of the pause is to make sure that everybody in the room hears the same thing. They might look at the x-ray and say, yeah, it's the left foot we're taking off. They might talk about, have someone read from the history and physical from the clinic where they say, yeah, I'm going to have to take off the left foot. They might have everybody introduce themselves, and it's actually very powerful to make sure that everybody's on a first name basis, so they introduce themselves to one another. And the surgeon might talk about, yeah, we're going to put in an XYZ implant, and let's make sure that it's the right size of implant, and do we have the implant? And the scrub nurse or whomever it is looks at the implant and says, yes, sir, we have the implant, and do we have the trays necessary? Yes, we have the trays. And okay, we're good to go. Get the anesthesiologist to talk about what the plan for anesthesia is. Everybody's on the same page, knows exactly what they're doing, they're going forward. And there's been an effort to flatten the hierarchy. Everybody has had a chance to chime in. And if they know each other on first name basis, it's something better. So now whether they might check that off on their documentation, whether they actually do it is subject to audits in the operating room, and it can be very difficult to do. But at the last Joint Commission survey, I witnessed an orthopedic surgeon doing it so well it almost brought tears to my eyes. It was absolutely fantastic. And when you see this actually happening, it's really, it's the way it ought to be done, and it's a very impressive thing. But it's improved the safety of American operating rooms dramatically. So within that culture, there actually was a point I'm trying to get back to. Within that culture, for most people, we've gone from looking at outcomes taken off the wrong foot further up the road. So now we have processes that we're very confident lead to good outcomes. And we don't have to anymore look at the outcomes. We can look at the processes that lead to those outcomes. So just as Elena was saying, did they check off that they did the pause? But it's not just the pause. If you audit in the operating rooms, did they go through all the steps of what should be contained within the pause? And you can audit that. And if they did, great. If they didn't, and if they don't routinely, and if you get word from the nursing staff that they don't routinely go through this with Dr. Smith, then you need to talk to Dr. Smith. So the example really, I heard Doug Bonnicum, a patient safety expert, speak about this. He said, really the example is, I get up in the morning and, I'm a little late, and so, I get my coffee, but I take my coffee into the car with me, and, because I got the coffee, I can't really do the seatbelt, but, and I like to drive about 7 miles an hour over the speed limit because that's where I don't get the ticket. And so I got my coffee there, but I also like to listen to music. So I got the music going, and I have to adjust the channel and this and that, and I'm a little distracted. Actually, I've got to give a chair there are meetings, so I got a thing I want to rehearse, and so I got my index card, and I'm going down the freeway. So, and I've never had an accident. Okay? So, are those bad things to do because he's never had an accident? I never had an accident.
He's an accident waiting to happen, though.
And that's exactly what our operating rooms were without this sort of thing. If you don't look at the processes, you're an accident waiting to happen. So what really happens mostly these days in most hospitals, I think, is an attention to whether physicians and other hospital personnel are following the rules that result in safe outcomes, and less of a focus on the outcome. So because there's less heat associated with the interventions, what we see basically is a lot of people getting put on work plans because they're not following the processes, which is way removed from the bad outcomes and way removed from all this HICWIA stuff and things that necessitate reporting, but it's where the work ought to be. You want to catch things upstream from the bad thing happening, and so therefore, if a surgeon is doing a bad timeout before the procedure, she ought to get a talking to, because she needs to do a good timeout. So gets a talking to, gets a work improvement plan at the next reappointment. The chief says, no, there's a little bit of a problem here with her. The credentials committee, which is the people that do the vetting of the reappointment folders, looks at that and says, oh, well, okay, well, there's a problem here. What's the problem? The department chief writes down, she wasn't doing good timeouts, and so we've intervened and we're auditing her timeouts now, and she's had 3 months of good results. The credentials committee says, oh, okay, so we'll recommend her for reappointment. It looks like the department chief is on the issue as she goes forward. So we don't really have to get to the point where she takes off the wrong foot, because we've intervened sooner. And because we've intervened sooner, I don't have to go through B4 and B5 of the bylaws as often. Now, if she never can seem to get it right, well, that's a different thing. But most people can see the light, especially when they're process things. So I wanted to give a sense, although we've talked a lot about the punitive nature of intervention with physicians and with professionals, really, you've got that on the one hand, but on the other hand, you want to foster a blame-free environment where there's a culture where people communicate and are willing to communicate with one another and don't feel like something really bad is going to happen if they do communicate, just like in the operating room, where you want to flatten the hierarchy. You want to have the nursing staff in the ICU be willing to talk to the intensivist at 10 o'clock at night by phone because the patient's coughing, or whatever it is. And without that ability to communicate, so it's a balance. It's a difficult balance. We really look at in here we look at the regulatory, more the punitive actions. The bylaws are more punitive, but the reality is the work goes on down here to try to accomplish that culture of safety to help make sure that our patients are safe. Barbara, did you have anything else to say about that? Or anyone else?
Like I was even interested to see if you had a self-evaluation process with yours, because there is the self-evaluation obligation there also. That yes, I may feel like that this surgeon's been yelling at me for a long time, but I also have that obligation to self-eval my practice, and if it's not meeting standards, how do I get resources for myself around that, instead of waiting for someone to come to me and say that I notice your practice is out of line. So I think one of the things when I've been working with Just Culture is the balance of also self-responsibility along with the culture. Sometimes I see people use the culture as an escapism versus my own responsibility to contribute to improving that culture versus complaining about the culture or feeling victims of the culture. That I also have an obligation to improve it. And so should I have that repetitive relationship with the surgeon that I'm not performing to my level of responsibility, I have the obligation to go up the chain of command or to continue to report that until the culture gets improved.
Yeah, that's a good point. It's a very difficult thing to change a culture, but that's where American hospitals are heading. And actually, there's a quality improvement, a quality class, and there wasn't even much in that talking about just culture and that sort of thing. So this is, it's prevalent, and it's even put into Joint Commission standards, but it's a fairly it's fairly new.
Right. And you think about that we're obligated to take a pain CEU, everybody is, but
Right.
we've known about human factors awareness for 12 or 13 years now.
It'd be-
IOM resurveyed of 2005 and said we're not paying attention.
It'd make a lot more sense than the pain thing, wouldn't it?
Right,
Yeah, no,
because it's the number one way we refer patients.
yeah, no, I completely agree. Yes.
Yeah, one of the things that I think when I went through nursing school, we were being taught more of a confrontational communication style, which didn't fit with me at all.
Oh, yeah.
And I think a lot of it is just teaching people to communicate without being confrontational.
So it's aggressive versus assertive?
Right. So, and one of the things I noticed when I was working in the ER and the ICU was that I could talk to physicians about something that, even if they were angry or whatever, I could usually talk to them just because of my background and work something out or call something to their attention because I didn't come to them in a confrontational style.
Mm-hmm, mm-hmm.
And they were much more receptive to listening. But a lot of the nurses had been taught a confrontational style.
Yeah,
and
that's
so you
interesting.
instantly
Really?
end up with that hitting against one another, and then you've lost it right
Wow.
there.
You know,
So-
there are techniques for approaching physicians. You know,
Yeah, there's-
and getting
well-
them to listen to you. And so a confrontational style is not one.
No, it is not one at all. But when I was in nursing school, and this was, and I've noticed that some of the newer grads are being taught a little different. But when I went through nursing school at University of Portland, we were being taught to be confrontational, which really went against my
Wow.
grain and everything that I was
Wow.
and I
Yeah.
just refused to do it because that was not my personality and that was not the way that I approached people.
Yeah, that's interesting. I wasn't aware that some nurses were taught that style.
Mhm.
That
The
would
flip
be-
side is, there was a generation where you gave up your chair when the physician came on.
I miss
You
those
did.
times, don't
So,
I?
I mean,
Yeah, right,
yeah.
yeah.
I mean-
Yeah.
Here's the-
Yeah.
So it was, that was the reaction.
And yeah.
The reaction to that was it.
And our society tends to do that everywhere. They completely overcompensate
That's what
when
it
they
looks
go
like.
to
That's what it
correct
sounds like.
something and instead of going to a middle ground.
Don't you miss those white hats? Yeah.
No. I actually got a hospital in New Orleans. When I first came out of nursing school, one of the hospitals still required those. And the supervisor made me go out and buy a hat to wear. Well, it ended up in a bedpan right off the bat, and I just set it on her desk. And I said, "This is why I don't want to wear a hat." And they actually changed. I set it in a case and put it on her desk and with a note. And, and it was one of those things where I was never required to wear a hat after that, and
No,
that went away.
I missed that era too.
My mom got married in one of those hats.
It was
Oh my
they
God.
were horrible because I was
Just had
working on an
everything
ortho-neuro floor, and we were
Right.
always getting caught up in the trapezes and the traction.
Actually, there was one nurse in my training up at the VA who wore a hat and felt that the answer to any malady was enemas.
That's wrong.
I think. Well, she was. I think that's very, very old school. So she was very old school. Well, we should have. I wonder if we're supposed to have lunch here
They
somewhere.
have tables in the hallway too. I wonder if they put them in the hallway.
Maybe put them in the hallway. But I think we have until 1 o'clock, and Barbara should be here at 1 o'clock if there's nothing else for us to discuss with regard to the medical staff structure. Near and dear to my heart, but only worth about an hour and a half. So, okay.
It's not on.